For example, the state operates on a forecasting system to some extent in terms of how they're going to spend money. They have to have forecasts. Well, how many kids are going to need to go in foster care? How many people are going to need to go to prison? So do we have to build another prison because we're projecting out based on the numbers that we're going to have this many more criminals who will end up needing imprisonment? Well, Eric, I don't know, was it last year, the year before that the state decided to literally forego building a new prison? And that's big money. I'll tell you, that is huge money when you're talking about foregoing building a prison. Based on a projection that if this many more, I'm sure, Eric, you know more of the details on this, but if a certain number of more kids in the juvenile justice system got functional family therapy, which has been shown to reduce recidivism in serious offenders by about 20% if it's done in the right way, and if more kids in the juvenile justice system got that intervention and you got these rates of reduction in recidivism, you would have fewer kids who went on to become criminals as adults. And therefore you'd have less need for another prison. Now when you have a government making a policy decision like that based on evidence-based practice, and it's something that I think we would all want. I don't think we're all hoping for more criminals and more prisons. That doesn't really always seem like the most constructive way to spend our money. But because of this evidence-based approach, they're taking a chance on it. Now I have to say that Steve Oates, who is the guy from the Washington State Institute for Public Policy who came up with these projections based on their research, he said, you know, well, he's not sleeping that well at night sometimes, hoping that he was really right. That, you know, it's one thing to have a small group of people who are getting it sort of a controlled dose and you can keep control of it. It's another thing to talk about reach, which is lots of people getting it and still getting those kinds of results. But I think it's a fantastically neat piece of evidence that this effort to bring evidence-based practices into our systems is making a difference not just in the lives of the individuals who are touched by the evidence-based practices, but in the whole public policy arena in terms of do we spend our money on prisons or do we spend it on health care? You know, that is a pretty neat thing to be contributing to, I think. Now, to go back to the workforce issue, which is what this initiative is about, I have to say, one of the biggest gaps I think that we have run into in trying to go out to community real-world settings and teach evidence-based interventions, we've learned that it's not that people are against the idea or won't try it if you approach them in a helpful way and give them the training and the consultation and all of that. But we find, startlingly, that many of the people in the workforce don't actually even know the basic principles that are the underpinning of these evidence-based practices. They are not unfamiliar with the basic principles, or they've heard of them, kind of, but they don't really know them. And I would say, hardly ever, and I think, Sue, probably this is your experience, Elizabeth, Shannon, when we do consultation calls, it is quite common that we hear people describing something that flies in the face of a fundamental principle and they don't really know that it does. I mean, for example, or they probably wouldn't be telling us. Yes, here I'm doing this useless thing. What do you think of that? But for example, the most common thing we hear that we're sitting there trying to find, you know, sort of a constructive way to respond to is people trying to treat kids with serious behavior problems by talking to the kid by themselves. I mean, we have a whole system right now, this bizarre system that has been developed, for example, for as school-based mental health care. And does everybody know what that involves? It involves a teacher saying, that kid is a behavior problem. I want somebody to see that kid. You have mental health people at the school who talk to the kid by themselves, and the parent is like, phew, I guess I don't have to do anything, because not one of them is coming into school to be in that treatment. Now, who is actually being served by this system? I'd say it's the teachers who have the kids out of the class. I mean, what's the principle that would tell us that you can change a kid's behavior problems without changing the contingencies and the responses in their environment? I mean, I don't think any of these kids haven't already been told, hey, cut that out. You know, and I'm not sure what else these therapists are doing with them except that, or processing their issues, or whatever. And these aren't bad people in any way, shape, or form. These are well-meaning, caring, decent people doing the best they know how to do, because no one has pointed out to them that you can't change. At least I don't know of any interventions that work without the contingencies being changed when it's an externalizing behavior problem. Or the other one that we almost never go a consultation session without hearing on this behavior thing. I got to say, we just have to tell people, all these people in mental health, they got the kid and nobody else. And the reason the kid's there is they got kicked out of school, the foster family's about to throw them out, blah, blah, blah. And they know they ought to have the parent there, but it's hard. And so they do the fallback position. Well, something's better than nothing. And a lot of us find ourselves, no, it's not. I mean, the something you're doing won't really work, and it's not really going to help anybody, including your reputation, that you're doing a treatment that can't work, and you're allowing the parents, the schools, the child welfare system to believe you can change a kid without that caregiver being a participant in it. That's not helping anybody, really. We need to start being honest about, but you got to know the principles to communicate them. The other one that I don't think we go a call without hearing about would be the I'm waiting for them to be ready. The reason why they're not doing the exposure part of the treatment. And of course we all have to repeat our little iconic story that Esther Deplinger, one of the inventors of TFCBT, tells at every training, and then we just repeat it because it's the best illustration you could have. She got a kid transferred to her after he'd been in treatment for a year with someone else, and the guy just knew he wasn't making progress with the kid, sends the kid to Esther. He's been going for treatment for his sexual abuse history. Esther says, I know you've been in treatment for a year for your sexual abuse history. Tell me how much you've been talking about the sexual abuse. And the little kid says, well, my therapist isn't ready yet. And of course that's more common than almost anything when you're doing consultation around an exposure-based treatment, is the therapist not getting that exposure is the cure, and that withholding the cure until someone's ready for it is really not going to get you to the cure. But that's a basic principle, that anxiety is treated by exposure. People should know that, because that's true for all anxiety disorders. There's no one ever got over a fear of flying by not flying. So that idea should be something that everyone comes with, that contingencies matter, that exposure is key for treating anxiety. And we need more of that in the training that people have in their formal education, because it's not a really good thing to be starting literally from scratch when people are already out in the workforce. And I don't mean to say that's always the case, but it's pretty common that people just don't have the grounding. So that's really kind of why I'm so enthusiastic about this whole workforce initiative and trying to figure out the ways to bring this training, whether it's learning about a specific evidence-based treatment package or whether it's getting really grounded in fundamental principles that are going to be relevant, because I think that we will be off to so much better of a start when people get out to the settings in which they're really practicing, and then it'll be a snap to teach a new intervention or to build on their skills, rather than having to bring people along as much as I think at this point in time we're having to bring them along.